Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode is taken from a live webinar, the third in a three-part series on ending the HIV epidemic. This webinar series features brief updates on key steps for addressing each pillar of the United States plan for ending HIV, followed by an in-depth question and answer session. During this episode, Dr. Judith Feinberg and Dr. Kenneth Mayer discuss the important role of HIV pre-exposure prophylaxis, or PrEP, for preventing HIV infection among at-risk individuals, as well as critical strategies for effective PrEP implementation among principal populations, including men who have sex with men, transgender women, heterosexual cisgender women, and people who inject drugs. For more information about Dr. Feinberg and Dr. Mayer, and for a link to additional educational content from this program, including downloadable slides, please visit the show notes for this episode. Now let's get started and hear expert insights on ending the HIV epidemic. Today's webinar is titled Ending the HIV Epidemic, Strategies for Preventing New Infections. Joining us today are expert faculty members Dr. Judith Feinberg from West Virginia University School of Medicine in Morgantown, West Virginia, and Dr. Kenneth Mayer from Beth Israel Deaconess Medical Center, Harvard Medical School, and Fenway Community Health in Boston, Massachusetts.
Good afternoon, good morning, everyone. It's a pleasure to be here with you. So we're going to be talking primarily about PrEP as a major vehicle for HIV prevention today. So it's important to note that PrEP is now approved for adolescents and adults weighing at least 35 kilograms, approved by the CDC, approved by the US FDA. What's really important when thinking about starting PrEP for an individual is being sure that they're HIV uninfected. So you want to have a negative HIV test. You also want to elicit a history to be sure that they don't have acute HIV infection, because antibody tests, even some that are fourth generation with antigen, may miss acute infection. So as clinicians, that's an important conversation for us to have. We obviously want to look at whether they're on contraindicated medications, things that might be nephrotoxic, for example. And you want to know their hepatitis B status, and preferably if they're hepatitis B seronegative, that they would receive appropriate vaccination. Now, there are two different FDA-approved PrEP regimens. There's FTC TDF, that's emtricitabine, tenofovir disoproxil fumarate. That has been around for a longer period of time, was first established as efficacious in 2010. That is indicated for all populations at risk for HIV. So there have been studies in heterosexual men and women, people who inject drugs, as well as men who have sex with men. But there is a creatinine clearance threshold that it should be above 60 ml per minute. Then there's FTC TAF, or emtricitabine tenofovir alafenamide. This is newer. Tenofovir alafenamide concentrates very avidly intracellularly, so you can give a lower milligram dosage of it. Very potent. Has been shown to be comparably effective for protection of individuals against HIV who are men who have sex with men and transgender women, but individuals who are born with the vaginas, so that would be cisgender women, transgender men, and other non-binary individuals who are born with vagina. The studies have not been done in that population. It does have a lower creatinine clearance threshold. One can go down to 30 ml per minute and prescribe it. But the challenge we have with PrEP is that it's underutilized. So the CDC estimates that there are about 1.2 million Americans who are likely to benefit from PrEP. These are primarily men who have sex with men, but certainly a substantial number of people who inject drugs and heterosexual adults who have not availed themselves of the benefits of PrEP. And the overall estimate is a little under 20% in 2018. When looked at just among men who have sex with men, if you construct a cascade of people who might benefit from PrEP, there's high level of awareness, there's a high level of willingness to use, but there's still underutilization. And this was an internet survey of men who have sex with men, clearly a population who might benefit from PrEP. So we have to think about how to scale up PrEP. The important thing to keep in mind is that places where PrEP has been scaled up are seeing a decrease in HIV incidence, which is really the goal of why we're talking today and overall our efforts in HIV prevention. Now, it's important to have a caveat here that these are not cities that weren't also expanding treatment as prevention or serostatus knowledge. So these were cities that upscaled testing, and when people tested positive, they made treatment available, and they had a social safety net to allow for the suite of services that people might need when starting antiretroviral therapy. But they also have been very proactive in developing programs for people at risk for HIV, which include PrEP. And you can see really quite significant reductions in HIV incidence. One important part of the puzzle is that for the largest group of people in the United States who will benefit from PrEP, we really have to know something about their sexual orientation, their sexual behavior. Now, it's important to keep in mind that these are separate constructs. Identity is what a person considers themselves to be. Attraction is who they find physically attractive. These do not necessarily map onto behavior. So as clinicians, we want to be culturally sensitive to people's lives and realize that all three of these different domains are important, but we want to create a comfortable environment so we can ask about people's behavior, because it's the behavior that defines PrEP risk. So, for example, just because somebody has the same sex attraction, if they're not having condomless anal sex with another male partner, they're not necessarily going to need PrEP. Conversely, somebody who is married and who identifies as heterosexual but is also having male partners and engaging in condomless anal sex would be a candidate for PrEP. So it's important that we keep in mind what are the things we need to know as clinicians to make people feel comfortable and affirmed in their identities and to support them, but also to understand behaviors and then to help them determine with shared clinical decision making if PrEP is an appropriate tool for them. We have to keep in mind that there are multiple different drivers of HIV risk. So it's not as simple as somebody is having multiple partners and that's why they need sex. It's who they're having partners with and what they're doing. There are a number of different domains that put men who have sex with men, MSM, at increased risk for HIV. This also includes transgender women for many of these issues. So number one, anal intercourse is a particularly efficient way of transmitting HIV because of the cellular structure of the colonic epithelium, which is very efficient for acquiring HIV, allowing HIV to replicate, and therefore being highly infectious. People who are sexually active may also acquire and transmit other sexually transmitted infections, and whether they cause inflammation and recruit cells that can transmit or acquire HIV, or whether there are ulcerations that allow for more efficient transmission of HIV, the STIs are a major cofactor. And then what's unique to people who engage in anal intercourse is role versatility. That individual can be the receptive partner and therefore very efficiently acquire HIV, but then can be an assertive partner with another partner and transmit HIV. But there are certainly individual behavioral issues because of societal stigma and internalization of negative attitudes by others. People may be depressed, people may have affective disorders or substance use, and this leads to poor caretaking and decision-making, which can lead to increased risk-taking behavior. People who think they're going to be disrespected may delay engaging in care. And so it's not only just condomless sex that is important with regard to individual behavior. Then there are issues of networks. There's some environments where people may meet partners more efficiently, whether it's certain bars or bathhouses online. This may lead to increased risk every time somebody has a new partner with these sexualized venues. And then there are these structural issues, which we as individual clinicians can't necessarily address on a macro level, but certainly by providing culturally competent and sensitive care, we can at least address on an individual level. We have to also pay attention to the fact that transgender individuals have some unique challenges. Certainly there is a robust literature that suggests delays in seeking care because of anticipated bad treatment. In many cases, there may be limitations in income generation, and that may lead to sex work. Partners may be individuals who are men who have sex with men who themselves are are engaging in other high-risk behaviors and therefore be more likely to be HIV infected and transmit HIV. And certainly there are questions about biological vulnerability in terms of the different tissues post-surgery. And certainly some of the literature would suggest that individuals who are transgender, it'll be very important for them to be highly adherent to PrEP in order to have maximal benefit. The other issue we have to be aware of is that we have an epidemic in the U.S. In terms of new HIV infections that disproportionately affects Black Americans, Latinx Americans, and so you have the nexus of sexual orientation, gender identity, as well as race and ethnicity, and individuals who have these intersectional identities where they're a sexual gender minority person who's in a racial ethnic community may experience homophobia from their natal community, from their cultural community, but they may also be experiencing racism on part of the gay community. So there may be multiple internalized stigma that lead to more avoidant behavior and more adverse health outcomes. So programs have to be culturally tailored and culturally sensitive with regard to paying attention to people's race and ethnicity. In terms of culturally competent care with regard to sexual and gender minority patients, and that's what the SGM abbreviation stands for. So that would include gay men, bisexual men, as well as transgender women with regard to HIV. We've talked about the reticence to disclose information because of anticipation of getting bad health outcomes. And as healthcare workers, many of us are unaware of the diversity of their patients, and it's a don't ask, don't tell kind of situation, which is really not conducive to making people aware of preventive modalities that can keep them from becoming HIV infected. We have a kind of role with regard to providing health information and social support that may be unique and really are in the best position to be able to afford patients the kind of care that will lead them to engaging in behaviors such as using PrEP that will protect themselves. And we have to think of culturally competent care as a basic human right and essential for optimal clinical outcomes. So there are a variety of resources. Shameless plug, our National Center for LGBTQIA plus Health Education at Fenway Health. If you just log in LGBT Health Education, you can get to the website. The website has a number of resources that have been supported by federal funds that are available for you to download and that can assist you and your practices in terms of how to elicit sexual histories, the best ways to provide care, and to understand what the implicit biases we may have when dealing with sexual and gender minority patients. And with that, I'd be happy to turn the podium over to my colleague, Dr. Judith Feinberg from West Virginia University School of Medicine.
Thank you very much, Ken. It's a pleasure to be here today. Thank you all for attending. So let's talk a little bit now about women and HIV and why PrEP's important for women. And in this slide, we're talking about the global picture, not just the United States. And new HIV infections are actually quite a bit higher, 44% higher in young women compared with young men globally. So in 2016, there were 900,000 new HIV infections in women, and actually the estimated incidence among pregnant women is a little over 3.5%. And part of the issue here, of course, is that women do not control, they're not always in control of safe sex. They may not be able to control condom use in many situations. And you can see on the graph on the right-hand side of the screen that it's an interesting inversion of colors, as usually women are red and men are blue, but you can see the 44% gap there. Okay. In this slide, we have summarized five of the studies, PrEP studies that have included women. Some were only in women, like the VOICE study and the FemPrep, and then TDF2 and Partners PrEP were both studies in heterosexual men and women. And the Bangkok study was a study in people who inject drugs in Bangkok, of whom 20% were women. And you can see that when you look at the meta-analysis regression estimates by adherence, that women do as do men, actually. Everybody does far better if they are taking enough of the medication to get a protective level of tenofovir and FTC in their blood. In the next slide is another graph where we have placed all of the published PrEP studies on a single scale. And you can see that the studies, and most of the studies in men who have sex with men and in heterosexual couples, cluster at the upper end of the scale. But the studies that have primarily been done only in women cluster at the bottom. And the reason for this, we have discovered, as we have done these analyses, is that in these studies, women were not very adherent to taking the medication on a consistent basis, whether that was a tenofovir vaginal gel or whether that was pills. Or emphasizing again, it's only going to work if you swallow it. So this is a slide that shows you the famous New England Journal of Medicine article that described the outbreak of HIV in Scott County in southeastern rural Indiana. But this was quite a surprise to the CDC when it happened. This is the first significant outbreak of HIV in a rural setting, and the first time in many years that HIV was being efficiently spread by injection drug use. And that had really been dealt with in the 90s and early 2000s by the development of syringe exchange programs. So here we were in a rural community of people who were injecting this painkiller Opana, oxymorphone, and required lots of injections, lots of times a day. So there was this, not only were people injecting and sharing materials, but this particular drug, because of its insolubility and its half-life when injected, really required multiple injections just for a single episode of getting high. So the changing face of HIV among people who inject drugs can really be seen in this slide. On the left-hand side, you can see that, in the earlier on, continuing from the 90s and into the 2000s, there was this steady, gradual decrease in the proportion of cases that were attributed to injection drug use. And then around 2014, this levels off. And actually now we are currently up to 9% so we have seen this really increase. 9% of new HIV infections are required through injection drug use. And in the graphs on the right, you can see that this happens primarily among whites, primarily among young adults, teens and young adults, and primarily in more rural settings. So the Scott County outbreak was a harbinger of things to come. Let me switch for a moment here and talk about what we like to call the 5 Ps for sexual behavior history taking. And they are partners. One has to really ask without any kind of prejudgment in your voice or your manner or your facial expressions. Have to ask people, do you have sex with men, women, or both? And then how many partners? And then over the last 2 years, the last 12 months, the last 2 months, and, do you have any idea whether your partners have had sex with someone else while they were still having sex with you? You need to ask women about, actually, not a bad idea to ask men either, about pregnancy, childbearing, child-making intentions, and certainly whether women are planning to get pregnant. And if they are not planning to get pregnant, what they are doing or thinking about doing to prevent pregnancy. Need to discuss protection from sexually transmitted infections, because while PrEP will certainly protect you against HIV, it's not going to protect you against syphilis, gonorrhea, chlamydia, etc. And as Ken had really talked about before, it's really important to understand your patient's practices and sexual preferences for the practice of sex. It's not enough, as he said, to sort of identify, have a label, but you have to know what it is that people really do. And so you need to ask, do they have vaginal sex? And sometimes you need to be very descriptive about this. And what is their condom use? Is it occasionally? Is it always? Is it never? Do they use condoms with people they don't know very well, but their most long-term partner they don't use condoms with? I mean, these are the kinds of things you really need to know. And then, of course, in terms of past medical history, you really need to know whether they've had sexually transmitted infections in the past. These are all the key things to history taking. And as we learned before, there are nowhere near as many people getting PrEP as could benefit from it. And that's because there are some real barriers to PrEP. And so some of these are things that we can help our patients with. So, I mean, first of all, there's awareness. And so educating your patient about sexually transmitted infections, including HIV, it is important. It's important to understand whether your patient, him or herself, perceives themselves to be at risk of HIV. I take care of a fair number of people who inject drugs here in West Virginia, and in general, they don't see HIV as a risk. They see hepatitis C as a risk, but they're really not very tuned into HIV at all. Stigma is a very important and critical obstacle to anything about sexual and drug behaviors, and certainly specifically here to PrEP. That people need to feel like that you are addressing them and talking about PrEP in a way that is not stigmatizing, and that your concern is really for their best interests. There's the ongoing issue of provider bias and distrust of the healthcare system. This may be particularly marked among racial and ethnic minorities who have been not ideally treated in the past, but also behavioral minorities like people who inject drugs, who also typically sort of have often gotten short shrift from the healthcare system and tend to avoid it unless it's absolutely necessary. So this is something that you and the people you work with can be more and more aware of and try to address. And then, of course, there's always the bugaboo in the room. The access to medical care can be limited in the significant minority of states that haven't accepted the Affordable Care Act. And so there's places where people with low incomes still lack any kind of systematic access to health care. Or in a place like West Virginia that is very rural, just the rurality itself is a real obstacle to accessing health care. And then, of course, financial assistance. In addition to having insurance or not having insurance, there actually are, of course, there are patient assistance plans for getting PrEP medication. And then you need to, obviously talk to people about what are the potential side effects and how, if they encounter them, how will they cope with them, and sort of game that out ahead of time so that the first time somebody feels a little nauseated or has a headache, they don't say, the heck with these pills. So I think we are ready to move on to our question and answer session, Jen.
Great. Thank you both, Dr. Feinberg and Dr. Mayer, for the presentation, the didactic portion. And we have had quite a few questions, so we'll move into that section now. Excuse me. The first question is from Amy. Amy asks, are there any studies that look at transmission risks when having receptive neovaginal sex in a trans woman who has had vaginoplasty?
I'm not aware of any data like that. Are you, Ken?
I am not either. And I don't, transmission studies are very hard to do. So there haven't been sufficiently large cohort studies of transgender women. There have been some descriptive studies and, mainly showing that the prevention cascade attenuates very quickly, and really arguing for culturally adaptive care. There are theoretical concerns about healing tissues, and that's why I made the comment that we think the data would suggest that one needs really good adherence, daily adherence to optimize the benefit of PrEP for transgender women. With regard to the hormones, there's certainly not a problem in terms of tenofovir, whether disoproxil fumarate or alafenamide and procydamine affecting hormone levels, and that had been a concern voiced by some members of the transgender community. But with daily adherence, we think that PrEP should be quite effective. The data would suggest that.
Great. Okay, we have a quick question from Cassandra just asking for what SGM stands for. That's sexual and gender minority patients. We have the next question is from Jacqueline. Jacqueline asks, is Hep B negative status an eligibility requirement for PrEP initiation because TDF is a treatment option for Hep B?
I think the issue here is because people can stop and start PrEP. Yes, it is true that tenofovir is a pretty effective treatment for hepatitis B, but if you summarily stop taking PrEP, you can have, a rebound, and sometimes it's even symptomatic, a real rebound in hepatitis B activity. So you really want to talk to people who are Hep B positive about that potential risk. And certainly people who come into and are sexually active and are taking PrEP because of their sexual activity, if they're Hep B negative, certainly you want to vaccinate them so that they're protected from acquiring it, because it is, of course, sexually transmitted. You have something to add to that, Ken?
I agree with everything you said, and I think in terms of the counseling, the important thing for the person who's ready to start PrEP, if they have chronic hepatitis B infection, is that they have to be prepared that they can go off PrEP because they may not be sexually at risk anymore, because PrEP is not necessarily a lifelong commitment. But once they start PrEP medication, they'll have to be on some antiviral to suppress hepatitis B to avoid the kind of problems that Dr. Feinberg mentioned. So that's the consideration, that as long as they're an informed consumer, we'd certainly rather somebody with chronic hepatitis B be on PrEP if they're putting themselves at risk for HIV.
Great. Okay, great. The next question is from Marilee, who asks, which populations would you consider using TAF instead of tenofovir alafenamide instead of tenofovir disoproxil fumarate in, if any, as the preferred first pick?
I'll answer that first and then let Ken chime in. There are different side effect profiles for these two combination PrEP regimens. For the tenofovir containing regimen, there's the issue of potential impact on bone density and more likely some impact on renal function. For tenofovir alafenamide, instead it's weight gain and increase in lipids. So neither one is sort of a get out of jail free card. And to some extent, you would want to think about which set of potential side effects are the ones that your patient should avoid. You also have to remember that the FDA, because there were no studies done with tenofovir alafenamide in heterosexual women, the FDA approval actually excludes women having vaginal sex from, it doesn't mean you can't do it, but it's not the way it was approved. I think the last thing to consider is that we've had FTC TDF PrEP for almost 10 years. It has a well-established safety record and is now generic. So there's also now, on top of all the medical decision-making, a financial implication as well in terms of the costs that the patient and or healthcare system are going to have to bear. So, I think those are the things that you need to take into consideration. Ken, you want to add something to that?
Yeah, I agree with the issues you raised, and I think the only fine point I'd say is that the differences in terms of the potential toxicity profiles are subtle for the most part. In other words, they are statistically significant, but not necessarily clinically significant for most people. But there clearly are populations where there's a definite reason why you would pick one over the other. So certainly somebody who has poorly controlled hyperlipidemia, I'd probably be more disinclined to start TAF versus starting a TDF-based regimen. Conversely, there's an absolute threshold. If somebody has a creatinine clearance between 30 and 60, who's male at birth, that person should be on TAF and shouldn't be on TDF because we have a perfectly good option. But, somebody who has hypertension and creatinine clearance is 80, I'm certainly not going to say, TAF is so much less nephrotoxic, I started automatically. But if the person's creatinine clearance without any other explanations started decreasing, then I might consider switching to TAF. So I think the really important thing is that the studies definitely show they're both very effective for this indication, for protecting people against HIV. And so it's nice to have two different medications in our armamentarium so we can, try to titrate the medication, thinking of all the patient's needs. And certainly their insurance and reimbursement status has to be a consideration as well, given the price differential.
Great. Okay, the next question and comment is from Michelle. And so it starts out with a comment. And so Michelle notes that many Black and Latino women are being denied PrEP by providers, primarily providers who don't see them as at risk. So she notes even women who are in relationships with men living with HIV are sometimes denied PrEP if their partner is undetectable, has undetectable virus. So she's wondering if you could address how the U equals U message, undetectable equals untransmissible, and the implicit bias affects uptake of PrEP by women of color.
Well, I think in my experience, it's not only racial and ethnic minority women, but women in general. For some reason, the fact that HIV primarily entered the United States and was first really recognized in men who have sex with men seems to have affected people's thought processes for the ensuing decades. So I've also seen this happen to white women. People just do not think that women, I've asked women that I've taken care of, well, what did you think? And they've said to me, I thought this was a guy thing. I thought this was something only guys got. So it is, I think, exacerbated in minority communities, but I think there's just a widespread belief that women somehow are just not at risk. And I think even in the situation where you have a partner who's undetectable, right? And we all know now that the phrase is undetectable is untransmittable. You have to have a lot of certainty that that this couple are only having sex with one another and that there's not something else going on. And I think it's reasonable if a woman comes to you and says, I'm interested in PrEP, and even if she tells you her partner is undetectable, if she's interested in PrEP, she should have access to PrEP. I think there's no question about that. So that would be my take on it. Ken?
I totally agree. I also think that it again gets back to how providers have conversations with patients. And I think that sometimes providers make presumptions about women's sexual behavior that make it very uncomfortable for a woman to say, well, I have had a partner on the side. The other issue about U equals U, it definitely works, but it also means that in the couple, the woman has to have a certain level of security that her partner is adherent and that there are not lapses at times. So certainly it doesn't seem appropriate to presume too much, because usually people are not looking for medication that they, a daily medication that they need to be taking. So there may be underlying reasons that may sometimes come out in the clinical conversation. And I've certainly heard of several cases where this has been a situation where the woman asks, initially doesn't give a history that sounds like there's a lot of risk, but as more trust builds up with the provider, more details come out that explain what the thinking was.
Okay, we have a question from Laura asking, do you find that being on PrEP makes a patient less likely to use condoms or other forms of protection to prevent other sexually transmitted infections? She mentions that there is education around this, but she's just curious what your observations have been.
You want to start? I mean, I can certainly start. it's a complicated question, because part of the reason that some people initiate PrEP is that they don't want to use condoms. It's not, that the thing that they're most concerned about is HIV. If they're adherent to PrEP, they're not going to have to worry about HIV, and therefore they don't see the need to use condoms. Part of what the onus on us is to educate people that PrEP does not protect you against other STIs. Again, if we use a harm reduction model, I'd rather somebody take PrEP than not take PrEP who's engaging in condomless sex, but I certainly won't not educate them about condoms, and hopefully they can be an informed consumer.
Mm-hmm. And I would say my experience is, of course, this is very individually driven, but I have certainly taken care of people who have stopped using condoms, who were diligent condom users before they got on PrEP, and then felt so protected by the PrEP that they stopped using condoms, and then had to be treated for syphilis, etc. It's not everybody by any means, but it does happen.
Mm-hmm. So the important guidance there is just continuing STI screening. Those STIs can be treated, and patients who are receiving PrEP.
Well, screening and education, just because making sure that people know what they might be at risk for, so that they can be an informed consumer.
Great. All right. I'd like to thank you both for that excellent presentation and really insightful answers to these questions. And then lastly, I just wanted to let everyone know that this webinar is part of a larger program on ending the HIV epidemic. I mentioned at the beginning, there will be a comprehensive video module coming out soon on prevention. There are currently video modules on diagnosis, as well as treatment, and downloadable slide sets, as well as on-demand audio. So please be sure to visit the CCO website and check out those educational resources. Thanks everyone for joining, and I hope you all have a great rest of your day.